you very much. I was saying that there is connected Dr. Elena Panettieri. She will present this case. So Elena, please.
Good afternoon, everyone. So this is the case I will present. We're talking about a 49-year-old woman in good health conditions, no other relevant diseases in her past medical history. Basically, this patient underwent an ultrasound of the abdomen for other reasons, and there was an incidental finding of a cystic mass in the left liver. Because of that, she underwent CT scan and MRI that showed the presence of sorry, I cannot see my presentation anymore. Okay, of a 7-centimeter complex mucinous cyst in segments 2 and 4, communicating with the primary and left secondary biliary bifurcation. There was a bile duct dilation of the left intrahepatic bile ducts, and the common bile duct was dilated with narrowing of its distal portion. Bilirubin, GGT, alkaline phosphatase, CEA, and CA99 were all within normal range. So now I'm going to show you the CT scan. So we can now start to see this cystic mass, and we can see that it is a complex cyst and that there is this mucinous component that I was talking about. It is very easily seen. We can see the bile duct dilation, and we can see also the compression of the portal structures. The right liver is completely normal. Now you can see the MRI. Even here we have a very good detail of the mucinous component. Probably it's an intrapapillary growth of a tumor. And here you have two nice images of the cholangio MRI. So you can see the cyst and the communication with the biliary tree. So our clinical suspect is that this is an intrapapillary mucinous cholangiocarcinoma in the context of a congenital common bile duct and left intrahepatic bile duct dilation. And our plan would be to perform a left hepatectomy with common bile duct and main biliary confluence resection. So our question for you is, do you agree with our interpretation and with our clinical plan? What would you do? Would you do something different? Thank you.
Elena, can you show again the MRI? Because it seems to me that also the right ducts are a little bit dilated. And
yes, because it is in communication also with the main biliary confluence.
Exactly.
CA99 was normal.
But actually, at the cholangio MRI, the right intrahepatic ducts are thin, are not dilated. Elena, if you can show the cholangio, I don't know if you have all the sequence. No, you don't have the.
No, there were not many sequences. Okay. Those two were the most relevant, I would say.
Fine.
I can show that to you again if you want.
For example, one of the first discussion with our hepatologist to perform a biopsy. I don't think that we need a biopsy. I don't know, what do you think about it? The other question we discussed with our radiologist is the interpretation of the dilatation of the common bile duct, which in our opinion is a congenital dilatation of the common bile duct and of the left biliary ducts. So in a anomalous congenital dilation of the bile ducts, common bile duct and left, and they instead consider that kind of dilation the consequence of the chronic cholecystitis. You see, there are stones in the gallbladder, and so we discuss with them about this point. And the final question is, do you think is, of course, I think it's necessary to resect also the main bile duct confluence. And so thinking about the possibility to perform a right hepatic duct jejunostomy. Yeah. The patient is very young because he's 40, 44?
49.
49? Okay, 49.
Thank you. Thank you, Felicia. Thank you for you. Let me first speak about the nature of this dilatation. This dilatation is communicating with the biliary tree.
Yes. Yes, yes.
Yes. Normally, a mucinous cyst, is not communicating. A cyst communicating, that means a dilatation, a congenital dilatation of the intrahepatic bile duct is Caroli disease, which transform almost always in cancer. So you think about that?
Yes, actually, yes. It's not a diffuse Carolis because the right side of the liver is healthy.
You are right. Caroli is diffuse, but not always. Exceptionally, it could be unilateral. So that means you think at congenital dilatation of the intrahepatic bile duct on the right, on the left branch.
Yes.
Unique. It is unique. Only one dilatation. Only one cyst. With
one question, Professor Maina.
Yeah. Good afternoon to everybody, or morning, according to where you are. I think it's good to think of alternative diagnosis, but for me, here we have everything under the same hat. We have a degenerated intraductal papillary mucinous tumor of the bile duct. The dilatation of the bile duct can be explained also by the fact that this mass is mucus secreting and has been mucus secreting for a long time. And that's why the dilatation is mainly in the main duct. And it involves a little bit the right hepatic duct as well, because the flow of the bile is not unhampered by the mucus. And this is very similar to what we see in pancreatic IPMC. The treatment, the biopsy, I don't think changes anything because the treatment is the same. Resection of the main bile duct or not. I think the more useless biliary tissue you resect here, the better, because we know that even if the degeneration now is in the left liver, it is a field change along the whole bile ducts. So I agree with the idea that the more tissue you remove without functional sacrifice, the better. And analyzing the histology of the main bile duct would be helpful to see whether you have dysplasia, whether you have nothing, whether you have high-grade dysplasia, and the kind of surveillance you have to take. For me, I completely agree, straight away, left hepatectomy with hepatico-jejunostomy.
But the right hepatico-jejunostomy.
The right hepatico-jejunostomy, and going down to resect the main bile duct as much as you can.
Yes, okay.
And surveillance, lifelong surveillance for this patient.
Would anyone perform a PET CT for completing the staging, look for adenopathies.
I think it's a good idea if you can and you have it easy, but it won't change very much.
Mm-hmm.
Pietro, it is not clear for me why you want to remove totally the main bile duct.
Because I don't think it's useful to leave it. It is a dilated main bile duct, and it is epithelium that can be removed virtually without cost. Because I believe that this disease has degenerated in the left liver, but it is probably a diffuse dysplasia of the whole biliary system.
That means that you think the dilatation of the common bile duct is congenital.
I missed the bit of the presentation, but I don't think it's congenital. Unless, Felice, did you present? I missed the first bit of the presentation. But I think
we can show you once again the images, but the problem is that I'm sorry, it was not exactly clear the cholangio MRI, but it is very clear the difference between the right bile ducts, intrahepatic bile ducts, which are thin, normal, okay,
yes.
and the left bile ducts are dilated.
Yes.
Now, the problem is it enough to perform a left hepatectomy?
I don't think it is.
I don't think, because I think that the dilated common bile duct is a congenital disease.
Well, I don't think it's a congenital. I think it's mucus that has been there for a long time.
Yes, but there is nothing inside. Nothing visible, in the cholangio MRI and in the MRI, the actual
this is what we see in pancreatic IPM, IPMN.
Yes,
even if you have the mucus secreting tumor somewhere, the whole duct is dilated. And I think this is the mucus that in the long run has dilated the tumor, has dilated the duct. And for me, it's
yes,
anyway,
but in this, Pietro, yes, I agree, I understand. But if you have mucus downside, in the common bile duct distally, you should have dilated also the right portion of the biliary tree. Don't you think so? You should have a complete dilation, and more evident also on the right side. I believe.
I don't honestly. I don't know how the pressure of mucus transmits, because this mucus, it's in the whole system. I think it's much bile on the right and much mucus on the left, on the main. And mucus is not as solid as a cast. So I wouldn't expect a dilatation of the right, but I would expect a dilatation in the long run where the mucus is. And I don't know why mucus is not flowing up in the right ducts. But anyway, you will know, but once you've resected it, whether the changes are long-standing or not.
Yes, of course, we have to decide at the beginning if I have to resect the confluence, the main confluence. That's the problem. That's the key point. Because if I have to perform a resection of the main bile duct confluence, and therefore an hepatico-right jejunostomy, hepatico-right duct jejunostomy, or if I could do only left hepatectomy and surveillance, but I'm not be convinced. I don't know.
I would leave. Yeah. I don't want to monopolize the discussion, but I would leave a small collar of confluence to make a nice, good anastomosis on good tissue, and analyzing with the frozen section the parts that you're going to leave.
Professor Martu?
Yeah. Am I audible?
Yes.
Yeah. So, irrespective whether we call it a congenital dilatation or is it a part of disease process, it's a abnormally dilated common bile duct, whole of the extrahepatic system. Okay. Now, what possibilities? If we look at the congenital choledochal cyst, pipe, and there is
We missed.
hello.
I didn't understand exactly what you said.
Okay. So one thing is that this bile duct, extrahepatic bile duct, is not a normal appearance. So whether it's a part of the congenital dilatation, like choledochal cyst, and the whole pathology is a variant of the choledochal cyst with the intracystic papillary cystadenoma. Now, we also know that papillary mucinous cystadenoma can be multicentric. So there might be something sitting in the common bile duct or at the lower end, which we are not seeing it. One of the way to look at it is doing the endosono, which can pick up if there is a lesion in the bile duct also. Irrespective of that, I agree with your surgical plan. That is left hepatectomy with the excision of the extrahepatic biliary system and hepaticogynostomy to the right system, which looks normal.
Thank you, Manuel.
Yes, good morning. So a nice case, Professor Giuliante. I agree with Professor Anjo. I don't think this is a congenital dilatation. The thing with mucus is this, it's not the same pressure than having a formal bile duct obstruction. So the intrahepatic bile ducts don't dilate in the same manner than the extrahepatic bile ducts. As you can see, after the confluence to the right side, the dilatation stops. It's where it enters the parenchyma of the liver. I agree also with the surgical plan. It would definitely resect the confluence and make a hepaticojejunostomy to the right, and send in a frozen section of the ring of the anastomosis.
You listen to me?
Yes,
Yes.
Yes. It is, I think the point is, what is exactly the nature of the dilatation of the common bile duct? I agree with Felice. Why the common bile duct is so dilated and the right branch are not dilated? It's only dilatation of the common bile duct, which is a little strange. And we have no feeling there is an obstruction. If you consider that bilirubin and gamma GT are normal, this is correct? They are
yes,
normal.
exactly. Yes.
That means, in theory, there is no obstruction of the bile duct. That means that this dilatation is pathology by itself. And at that time, I agree with Pietro. It's better to resect it, but to let a cuff of the right branch in order to do a large anastomosis on the right.
Okay. Okay.
Everybody agree for that? It is what you said, Felice.
Yes, yes, I agree. I agree completely. Yes, yes. For
Pietro?
someone else, but I agree with your summarizing the problem. Yes. Okay.
Yeah. And there is an interesting comment of Tran, I think, to take away the caudate, of course.
Yes. Yes, yes, yes. Yes, yes. I was yes, of course. I had considered. I had the plan to take off also the caudate. Yeah.
Yeah.
Yes.
At least the caudate on the left. Segment 1 on the left.
Yes.
Because we say that there is no segment 9 here.
I agree. Okay. Thank you very much.
As M. Bismuth said, rien de neuf dans le 1.
Non, rien de neuf dans le segment 9. Parce que le segment 9 est une fantaisie de Quinault qui a voulu créer un nouveau segment avec la partie droite du segment 1. Et en fait, c'était une erreur de définition de sa propre nomenclature. Je crois qu'il a abandonné ça après. Et le 1 est resté 1, unique.
Très bien. We switch back in English now.
No, okay. Okay. It was only, we spoke in French only to say neuf et neuf. For neuf a two signification in French.
Ouais.
Okay. This is a nice case, Felice. Thank you.
Thank you. Thank you very much.
Thank you. Alessandra?
If we move to the second case, Sylvia, do you want to present yours?
Yes, sure. Thank you. Good morning, everyone, and thank you for the opportunity to present you this case report. I have also prepared, if you want to know, the result of the case report that I present at Lugano meeting. So today or next meeting, if you want, I could share with you the result of the discussion that we have before. But now I will present you this case. Are you seeing everyone?
Not the PowerPoint yet?
Yes.
Yes, the thing is, I see the whole screen. Maybe you can go on the PowerPoint presentation only.
I am already.
Open the presentation.
I am already with the presentation.
Then you have to interrupt the sharing of the screen and go back on sharing only PowerPoint. Meanwhile, Surendra had, and go on the presentation mode. Yeah, lovely. Perfect.
Fine now?
Yeah.
Okay.
Nice. Yes.
Okay, thank you. So today I will present you the case report of a 43 years old male patient with no medical history that in 2024, in the beginning of 2024, starts with a mild abdominal pain, performed an ultrasound that found a large lesion in the left lobe of the liver, and they performed at this point this MRI that I will show. We have this large lesion at segment 4 involving also segment 1, 5, and 8. And here other images. Too fast. I will go slow. Sorry. So a large lesion in these segments with the other small lesions in segment 3, 5, 7, and 8. Atrophy of segment 2 and 3 because of the compression of the hepatic vein and the hilum, but no vascular involvement at the hilum. And I want to ask you what you think. What will we do?
Have you an idea of the tumor markers?
Normal. Normal tumor markers at this point.
And no liver disease.
No liver disease. And no history of consumptions, alcohol, serologies are fine.
Any sign of cholestasis, GGT elevated or?
No cholestasis, blood work perfectly normal.
I have the feeling that we may say it seems more cholangiocarcinoma. The large tumor in the middle of the liver plus the small nodule in the right liver, it could be the diagnosis. It don't seem to be benign. It seems to be malignant, despite the fact that tumor markers are normal. Personally, I would like to have a biopsy.
Okay. So they performed, this was at the beginning at the other hospital. And yes, they performed a biopsy, and we have a net tumor, G2, with Ki7 of 10%. And they performed also a non-tumoral liver biopsy with no hepatic disease, only mild fibrosis. They continued the evaluation with Dot-NOC CT scan, and it shows us a massive hyperfunctional liver lesion and an ileal focus with the overexpression of the somatostatin receptors, maybe the primary in the ileum intestine, with no other lesions, no pulmonary lesions, and no adenopathies suspected. At this point, chromogranin and HIAA was elevated. And the patient performed a cardiac evaluation, and we have at this point in September 2024 some cardiac disease already from the carcinoid syndrome, tricuspid regurgitation and a dilatation of the right chambers. They performed also an MRI, a cardiac MRI with dilated right ventricle and right atrium and mild to moderate pulmonary insufficiency. At this point, the patient was come to our hospital to ask our opinion, and I would like to know what you think at this point. We have a very young patient with a massive lesion of a net tumor and carcinoid symptoms.
He has flush.
At this point, very few symptoms. Flush and diarrhea are sporadic. But in the cardiac evaluation, we have already signs of a carcinoid tumor, the dilatation of the right cavities and valvular dysfunction.
Do you have an idea of the volume of the normal liver?
We don't have that, but we know that we have more than 50% of the liver involved.
Look, Sylvia, what you suggest is in this case is a carcinoid tumor. Is jejunal, the ileal carcinoid tumor with liver metastasis. This is what you think?
Yes.
Plus, of course, as usual in this endocrine tumor, an impact of the heart. So I think that to do a ileal resection of the primary and a liver transplantation for in this case, there are multiple lesions in the liver, I think is, for me, acceptable. I don't know what you may propose for the heart, what kind of treatment, of it resolve, I don't know. But perhaps,
Okay, at this point, we thought we couldn't resect it. We know that
You have a few people raising their hands. Hope Trancao is.
Okay, Professor Pietro?
Emmanuel. No, I pass my.
Pass the baton. Good morning.
Good morning.
So Sylvia, in this patient, we'd have to review the imaging to look as to whether resectability can be achieved for the liver. But in our center here, we have a program where these patients, once they develop valvular disease, you tend to have a very bad problem of congestive hepatopathy. Essentially, the liver is going to be very congested to do surgery on. So the first thing that we would do is put them on medications or somatostatin to kind of try to limit the effects of the neuroendocrine carcinoid syndrome. But then we actually would refer them to cardiology, and we would work on arranging a valvular replacement or valvular repair first. And that's what you would do. You would do, cardiothoracic surgery to do a valve repair or valve replacement, which actually nowadays can be done relatively, quickly with rapid recovery. And once that happens, then you can arrange the next step with regards to addressing the metastatic disease in the liver, which, if it is, amenable to resection, debulking, kind of cytoreductive surgery, we would do. And if it were more significant, then I would agree with the Professor Bismuth that you can consider transplant. But if I can resect it, I would rather resect, even if it's not complete resection, primary and metastatic disease. But heart first.
I agree with you. I agree with you, heart first. In one of my first bad record of a case like this one, I did liver transplantation, and at the end of transplantation, the liver became pulsatile. For there was a valvular lesion, and the liver could not work. We have to do an emergency cardiac surgery. That means it is, as you said, mandatory to do first the repair of the cardiac lesion. I agree totally. And then, if you may resect, why not to resect the liver? I don't see clearly how many nodules there were in the other part of in the right liver. But why not? If it is possible to resect, good suggestion. I say that to open the discussion.
Manuel had also a comment or a question before?
No, it was exactly as Trancao said about cardiac first. I agree with this.
Yes, actually, we agree with all of you. We thought that we will have a very congestive liver, so the resection was not good at this point, and we prioritize the optimization of the carcinoid syndrome. So we propose start with systemic therapy. And optimization in the cardiology appointment. But at this point, our cardiology team doesn't propose the valvular surgery. They want to evaluate what is the response to the somatostatin analogous to the octreotide. So the patient starts the somatostatin analogous, but after a few months, the symptoms are worsening, diarrhea, flushing, and now tachycardia, diarrhea, and with a very low quality of life. At this point, the patient was in his hospital again, and they propose the patient for PRRT, the radionuclide therapy. Unfortunately, no results. And the patient starts again octreotide and everolimus to try to control the carcinoid syndrome. Unfortunately, at the other hospital, they proposed the patient for resection because of the symptoms. They performed a first attempt of liver resection, but they could resect because of the congestion of the liver, a lot of bleeding, and hemodynamic instability. And they didn't do anything at this first attempt. At the second attempt, 2 weeks later, they couldn't resect also the metastasis, the liver metastasis, so they performed the primary resection, a ileocolic resection. However, at the post-op, immediately post-op, the patient developed a carcinoid crisis, very severe, with compensation of heart failure. And they have to transfer the patient to a cardiac ICU, and the patient needs to perform an urgent, I have to say, pulmonary anticuspid valve replacement. But after this cardiac surgery, the symptoms getting worse. The patient develops carcinoid crisis almost every day, with significant severe hemodynamic instability, with 3 cardiopulmonary arrests. And here you can see the CT scan. Sorry for the quality, but this was at the other hospital. I only have these images. We can see the big lesion that we know already. No increment on the volume. We have at this point a patient in the ICU recovering from a cardiac surgery, but with carcinoid crisis that are causing a lot of instability. So they all call us again, and I want to ask your opinion now. Do you think that we could do something to get this better, to save this patient?
I have an experience of embolization of the tumor, and embolization of the tumor may reduce the size and stop the endocrine syndrome. I don't know what is your suggestion, but I am thinking about that.
Yes, that's exactly what we thought. We managed the transfer the patient to our hospital, and yes, we performed the embolization. We are worried about this is a very big lesion. We are worried about the necrosis and the possibility of an infection in this very ill patient, but we have nothing more to do. So yes, we performed the embolization. Here you can see the arteriography from the celiac trunk, and here from the left artery.
Yes. It is an hypervascular lesion, and normally it responds well. It responds well to the embolization. Normally.
Yes. And here after, sorry. Sorry, here we have the embolization. only the left embolization. Our radiologist thought that some vascularization was from the anterior sectorial artery, but they prefer to embolize only the left and see what happened. And after, if it wasn't enough, we could try the anterior sectorial. And here we have the stasis from the end of the embolization. This was 2 weeks ago. And after the embolization, no more carcinoid crisis, gradual reduction of the support, of the hemodynamic support. We still have some flushing and diarrhea, but sporadic. Stop dialysis. Is still on mechanical ventilation in a tracheostomy, through a tracheostomy, because of severe myopathy. We have 2 months of ICU and 3 surgeries. So he's very ill now, but he's getting better. The cardiac evaluation at this point, this week, we have right ventricular dysfunction with a TAPSE of 0.7. Normal is above 16, but it's getting better. The previous was worst, and a good left ventricular function. So this is the CT scan from the last week. We can see here, this is the arterial phases. We can see we have some vascularization, but very less than before. Another one. And at this point, I want to have your opinion again. Would you do something else? Would you wait for the rehabilitation of the patient, get out of the ICU, and try to resect or transplant the patient now? At this point, we don't have the primary. What is your opinion?
Today, what you know of the presence of tumor is only the liver.
Only the liver, yes. But in the liver, we have that big mass, yes, and we have a few lesions, 4 lesions in the right lobe, 1 in 8, 1 in 7, and another 2 in segment 5.
And the general condition of the patient. What said the cardiologist and the anesthetist?
Yes, the patient is very ill. He's getting better now with a less support, actually with no vasopressor support, but still on ventilation, invasive ventilation with a tracheostomy. And we can't disconnect patient now because he don't have accessory pulmonary muscles because of the myopathy. He's performing rehabilitation, a lot of rehabilitation, but he's still very ill. The cardiac function, he's better also, but he can't support transplantation at this point.
Look, I agree with Op say no surgery now. I agree. The embolization was very performant. Why not to do another embolization? It could be first only on the right liver in order to touch the nodule of the right. But we may repeat the embolization. It's not aggressive treatment. So I may suggest to do an embolization on the right to try to touch the small nodule remaining, and why not another step of embolization to the left and to wait. It's no time to do, it's not in good condition to have even resection of nor transplantation.
Okay, thank you. Professor Henry Adam?
Yes, I would agree on the fact that we are in an acute period. And so for me, there is no place either for liver resection or transplantation. We know also that some of these neuroendocrine tumor may be stable for a long period of time. So I will wait that the patient recover completely from this acute complication before considering the possibility either of left extended hepatectomy. If I have not seen very well, I would say the CT, but it seems that only the posterior sector is I would say, prevented by the tumor, or if the unresectability is confirmed at that time, to consider the possibility of liver transplantation. But presently, we do nothing.
Okay, thank you. But we have more than 50% of the liver involved. We are thinking in transplantation actually from the beginning, but we know that we have a G2 and no extrahepatic disease, but we have more than 50% of the liver involved. This is not a good outcome, but we are thinking in transplantation in the future. Do you think that? Do you agree with us?
May I say anything?
Please.
Could you consider also, okay, for no surgery, it's no time of any kind of surgery, I agree, but why don't you consider the possibility to make a radio embolization that, I mean, could be something which can prolong the stability and the control of the main disease, I mean, on the main mass. This could be, I mean, add to the effect direct of the embolization, also the effect of the, I mean, radiotherapeutic effect of the radioembolization. I would consider this possibility.
Okay. We didn't consider radioembolization. The patient has went to radionuclides therapy, but that doesn't go well. He only performed 2 sections and with absolutely no control of disease, so they stop it. But it's different radioembolization. We could think about it. Yes.
I would like to do an additional comment, sorry, is we may be reluctant to liver transplantation because we have no primary. But
Yes.
in the European series of retrospective evaluation of all the transplantation for neuroendocrine metastatic tumors, in fact, there were no difference between those patients whose primary has been detected and treated and those with unknown primary. So, I mean, the fact not to have the primary detected should not be an absolute contraindication to liver transplantation in the case that you go toward this type of treatment.
Okay, we detect the primary in the island, but at the other hospital they resected.
Yes, they resected because
they resected.
I was not knowing that. Okay, I missed
They
it.
resected.
Sorry.
After the resection, we have the patient decompensated a lot from the carcinoid crisis and cardiac decompensation. Maybe that's the surgery precipitated the compensation, because we know that after the surgical stress, the carcinoid crisis began more frequent. But yes, now we don't have the primary already.
But Sylvia,
Yes.
you said that the patients have no more carcinoid crisis. This is correct?
In 2 weeks, yes, after the embolization. Only
yes, and he's improving.
he's improving. Slowly, but improving.
Personally, I agree with you that we must achieve the treatment by liver transplantation, which is more radical. But today, I have the feeling it's not possible to do it. So the question is what to do in the waiting time, or to do nothing. He has a medical treatment now, and undergoing treatment.
No response at this point. No.
You said he did not tolerate well the treatment. So the question is to let him improve for some more weeks or months, and then do the liver transplantation when he's better, or to do something else. I propose embolization. It could be other treatments. I don't know what is proposed by the other.
Embolization or tear, maybe?
Yeah, what I said. I say on the right, for the right was not treated, and to repeat on the left.
Yes.
Repeat embolization.
We could
embolization is acceptable.
Yes, and we will have more time to the recovery and the control of the disease.
What is the opinion of the others?
I would agree on radioembolization, because as said by Felice, I think we may add the diminution effect, but also the atrophic, effect of radiotherapy. So I think it's a good idea.
I think it too, and but I think it was right not to use it at the beginning, after the surgery decompensated, because the effect is lower than the embolization. But now to consolidate the tumoral response, I think it's a very good idea, and it also induces hypertrophy of the right liver, which is a good thing to have. So I think at this point is what I would do. I think it's a most instructive and interesting presentation. Thank you very much, Sylvia.
Thank you for your inputs. Thank you.
Okay, Sylvia, so to conclude, what do you will do now? What is your decision?
We will think about the radioembolization. I think that is a good idea. If it's not possible, we have a limitation for the radioembolization. We don't perform radioembolization at our institution. It is in our institution, but other hospital. The mobilization of the patient is different, but we will think about the radioembolization. If we couldn't perform it, we will embolize the right lobe, the right artery, and more in the left. And after evaluate the patient and try to go to transplant. I have only one more question. In your experience, this right cardiac failure, heart failure, is only from could be only from carcinoid syndrome, or also because of the congestive heart failure, congestive liver failure, because of the vessels. We don't have flux on the middle hepatic vein, very small on the left, and a very congestive right hepatic vein. Do you think that this is the cause of the right heart failure, or only carcinoid syndrome?
I am not an expert because but in the few cases we have, it was due to the carcinoid syndrome.
Yeah, if anything, the congestion of the liver is exacerbated by the right heart failure brought about by the carcinoid syndrome.
Okay. So we could expect that this getting better with carcinoid syndrome controlled. Thank you. Thank you very much.
Thank you. Thank you, Sylvia. It was a very interesting case. Thank you.
Thank you.
We have a last case, another case from Lugano. It's Lorenzo that is presenting.
Hello, everybody. Do you see my screen?
Yes, not the presentation. Yes,
And now
Yes.
it's okay?
correct.
Sorry. Okay, this is the case of a 39-year-old lady under oral contraceptive for the past 16 years. She's completely asymptomatic. For other reasons, she had an abdominal ultrasound in May 2025, which showed a liver nodule of 3 centimeters in segment 4A8, and she underwent liver MRI then. This is the MRI. I can show you. You see the video? Okay. Can show it again. So there are two FNH, no doubt about diagnosis for the radiologist. One is around 3 centimeters at the passage of segment 4A and segment 8, and the other slightly less than 2 centimeters in segment 8. It's the smaller one, and it's at the hepatocaval confluence. You can see that. So the path on the MRI is clearly for FNH. But anyway, this patient had a second MRI 6 months later. She was still asymptomatic, but what the MRI showed is actually an increase in size of both FNH and some small angiomas. So the largest one in segment 4A to 8 was like increased of 3 millimeters, and pretty much the same was for the smaller one in segment 8 at the hepatocaval confluence. But she was still asymptomatic.
Right. Thank you very much, Lorenzo.
Yeah.
I was the one to insist on this presentation because normally what we say, FNH, diagnostics of certainty by a radiologist, no need for follow-up. But we have that we didn't ask for because the patient was just presented to us now, a growth in this in the lesions. And in fact, the one I really don't like for it to grow is the one at the confluent. And normally we say no need to follow up, no need to do anything, just go away and forget about it. Just remind the radiologist when you have a new MRI for other reasons. But here, I feel it was worth a discussion.
You agree? I agree, Pietro. You are right. You know, normally, to say that the liver tumor is benign, need to be 100% sure. It was the case in this patient.
Yeah.
Why? How the diagnosis of FNH was assured?
Our radiologists say that with stringent criteria, they are 100% sure. So the diagnosis here is not my problem. The diagnosis is FNH. But
He said that. He said that.
They say that 100%. And I agree because this is one of the service we render to society, because otherwise patients with FNH continue to have MRIs in case it's not an FNH. And in some patients, we cannot make the diagnosis, but in other patients, we say 100% and no follow-up.
You know, I think you know that
radiologic appearance of FNH and cholangiocarcinoma, intrahepatic, are very similar.
Yeah.
You know that.
Of course, provided the patient has no history of liver disease, no family history of liver disease, no lab signs and risk factors and all that. But we give it for granted. The diagnosis is not my problem here. It is the management that is my problem.
Only the biopsy, the histology may give 100%. I disagree with the radiologist.
No, you disagree with me because we push our radiologist to say 100%. Otherwise, we would have zillions of FNH to follow up because we can never be sure. We would have mobility from biopsies of FNH for which we're not sure. So we only follow up or biopsy patients in which we are not 100%. And I think it's an important point, and maybe it's worth a bigger discussion, and maybe we can present this case in Paris. We will not to discuss exactly this point, whether we need something else than a radiologist when the radiologist has all the diagnostic criteria for FNH. But it's open to discussion. That's why I wanted to hear your advice and also the others' advice.
I would agree, Pietro, that we have many signs in favor of FNH, but the point is that it is very unusual that FNH increase in size for more than twofold in a period of 6 months.
No, not twofold.
Not twofold? It is put twofold here.
No. It's 2 FNH, I mean. 2 nodules.
2 FNH.
But the nodule size, the increase was 3 millimeter for each one of the two. I'm sorry. No.
So if we use the same criteria that for malignant tumor, if we use a sort of RECIST criteria, even if it's a benign tumor, it's a stable tumor.
Yes.
So by this way, I will wait.
And in fact, I don't mind waiting for the lower one, but for the upper one, I don't want to find myself in 10 years with a Budd-Chiari there and wish I had done something before, 10 years before.
No, I would say whether there is a significant increase in size and at that time it's so unusual that why not to do a biopsy to confirm.
A biopsy there is not easy. A biopsy there is not easy.
But it's not the case. And so as it is not the case, I would continue to follow up this patient without doing anything else.
Yeah.
Why no biopsy?
I have a bad experience of biopsying FNH. We had a couple of patients who bled from FNH quite severely after the biopsy. Of course, you can embolize and stuff, but they were not symptomatic before, they became symptomatic afterwards. If the radiologist is happy, and if this lesion grows only marginally and stuff, I would say follow-up is fine. Surgery can be discussed. I would not do it. But I wanted also somebody else's advice. Maxime.
Yes, hi. I just wanted to share our experience for a similar case. We have a patient with a huge FNH involving the 3 hepatic veins. But this patient had a huge inferior vein from the right lobe, which actually drained all the drainage from the liver. So probably the FNH enlarged the inferior vein pretty much. So is there an inferior vein in this patient? Maybe this could help in the discussion or your
No, I think the inferior vein developed because your patient developed the FNH.
Yes,
Not
I think
something she had before.
No, it enlarged very much. So we had an old image of, I think, 10 years ago with the diagnosis of an FNH, and then follow-up stopped, and then she was referred again with a huge growth of her FNH, and the inferior vein enlarged, I think, fourfold. So maybe this could
that's
help
typical
you with...
Bucchiari. It's typical intrahepatic response to Bucchiari.
Yeah, but she didn't have any symptoms. So the inferior vein did it. Yes, indeed. Yeah. And then we did an embolization actually to stop the growth there. But she didn't have any symptoms due to the involvement of the three hepatic veins.
Mm-hmm. René.
No, thank you. I have given my opinion.
Which is follow up.
Just follow up.
With MRI or ultrasound that could perform also a Doppler on hepatic veins?
But sometimes they're not visible on ultrasound, these things.
Much better to compare the same examination.
Yeah,
so
I agree.
MRI.
Yeah, same modality.
Yeah. Tran, what would you do?
No, I mean, I agree, Pietro. I think that this is one where you can afford to just observe and watch. These tumors tend not to really compress, I found. They can grow along these veins and really not cause a lot of trouble. And you're going to be monitoring anyway, so I think you can intervene if there's some kind of some degree of growth that concerns you. You can always resect and enucleate at that time. But right now, I agree. I would just observe.
Mm-hmm. Surendra?
I think you can repeat an MRI after 6 months, because this 6 months you showed the increase in the size by 3 millimeter in both the lesions.
Yeah.
So another MRI after 6 months, and if you find it is growing at the same rate, then you have a concern there.
Then you have?
Yes.
I do think it's important to point out real quick, FNH can grow. It's not like they have to stay stable. So some degree of growth of an FNH is not something to kind of look at and say this is malignant, right? So I think you go by radiographic features. If there's a question, I would biopsy, but yeah.
All right. Thank you very much. Thank you, Lorenzo. Alessandra, do you want to take over as a moderator?
I think there are no other cases, but Sylvia had a follow-up of some case that she presented in the last meeting.
Yes, at Lugano. If you want, I could share. If you don't, I could share later or don't.
I think we have enough time.
Okay, so let me open here. This is a case of an hepatic aneurysm, a big aneurysm of the hepatic vein, of the hepatic artery. Sorry. Let me put here. Just can you see?
Yes.
Yes, okay. So the case was about a 60 years old male patient with obesity, and the patient was totally asymptomatic, but goes to a private clinic because of an umbilical hernia. And here in Portugal, for the security refundment, we have to have the imagiology confirmation of the hernia. So they performed a CT scan because of the umbilical hernia. And we actually saw this. here starts the aneurysma, intrahepatic, and goes to the celiac trunk. A very big aneurysma of the hepatic artery and goes to the right hepatic artery. We can see here, we thought that we have a left branch of an artery to the left side comes from the left gastric artery here, and goes along the wall of the aneurysm. Here, the left artery. And what do you think we could do here? Or I can go to the rest of the case. We thought that we could, we discussed in our multidisciplinary meeting, and we decide to perform an arteriography. And if the left artery is not involved, try to embolize the aneurysma and hope that we have arterialization from this left artery. So we did that. We performed the arteriography. Here you can see by the aneurysma arteriography by the celiac trunk. And here we select the left artery from the gastric artery, but we don't have vascularization to the right, so we abort the embolization. And at this point, I present this case in Lugano. We don't have, no one has a lot of experience in this type of big aneurysm, but your opinion was resect the aneurysm and watch the liver very closely. So that's what we do. We resect the aneurysm. Here we have the big mass, the big aneurysm. As you can see, the quality of the images are not so good, but I think that you can see all the mobilization of the aneurysm from the gastric wall, from the hilum, from surrounding structures. And after that, we dump and we resect the full hepatic artery. And here you have the final aspect with no arterialization from the liver. And here the aneurysm and the artery here. And post-op was uneventful. We are very surprised, but we don't have big damage on the liver function. At the day 2, we have 1,000 in AST and ALT, but with a rapid decrease on liver cholestasis. And here we have the post-op CT scan with very small arteries, but arterialized liver. We don't know from where, but actually the patient went very well, and with an eventful post-op, and went home at day 7. So actually, this liver lives without artery. Yes, Pietro, please.
Yeah, I commend you for several things. One, for the beauty of the gloves and the instruments that were immaculate. This is typically Henry Bismuth school, where on movies you have no blood. So one thing commended. The other is how you did the surgery. The third thing I would not commend you is for not having read the papers on the arterialization of the liver, because you know where this arterialization comes from, and it comes from the hilar plate. And it's called the W or omega circulation that you see when you have an artery to the left or to the right for that matter. Then you have the, from that hilar plate, you have revascularization of the arteries on the right, which is published and well known from a very long time.
Yeah, yes, we our concern during the surgery was precisely don't touch the bile duct.
Yeah, exactly. And did you have one thing to notice in that case is did you do a Doppler during the operation? Because it's almost immediate, this circulation, but also with a tardus parvus pulse. And you have backflow from the artery of the right, which is almost immediate. Mm-hmm. That doesn't mean that you must cut it always, but when you cut it, generally you get away with it.
Okay. Actually, we performed Doppler, but we can't find any artery in Doppler inside.
Probably because you were not hopeful.
I will continue with what said Pietro. There is many ways of bringing the arterial blood to the liver. I think there is a British anatomist who worked on, he published a paper, I may give you the reference, of the 21 way of bringing the arterial blood to the liver. There is also the diaphragmatic, small arterial from the diaphragm, from the round ligament. There are many places. And usually when you suppress the hepatic artery, we have a lot of examples of that. The liver non-suffer. There is only one case when the liver suffer on not having the hepatic artery. It is the graft, the liver transplantation. For the liver is totally free. There is only one way for the arterial blood in the graft, is the hepatic artery. But on the liver, on in situ, on a normal patient, I may say, there is a lot. What said Pietro about the rapidity of the arterial blood coming to any part? We observed this in a patient. We did an arteriography, and there was a spasm of the one branch of the hepatic artery. 10 minutes after, we redo the arteriography, and there was, it was the branch, the right branch was totally closed by spasm, and 10 minutes after, there was a collateral circulation coming from the left. That means it is very, very quick. It could be immediate. This is what you observe in the arterial circulation. We said that, for instance, if we look for the portal vein, this is slower. For the hepatic vein also, and of course, there is no way of collateral circulation between the two branch in the biliary for the biliary tree. But for artery, it is very quick. The communication between the two parts of the liver. I spoke about that. That means you observe something which is very interesting, but a confirmation of what the anatomy is described.
Yes, and I think that it's important that this kind of surgery perform that also. Don't mobilize the liver because of the vascularization from the diaphragm. So our thought was don't touch bile ducts and don't vascularize, don't mobilize the liver.
Just a question.
The anatomist, the British anatomist is Mitchell. The name is Mitchell. 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 He described all the way of arterization of the liver many years ago.
Just a question, Sylvia. Sorry. Hop is asking you a question.
Brune, you can start.
No. Go, Hop. You were the first.
I want to. So first, I think we have some evidence of this phenomenon, right? So, if a patient has a GDA blowout after a Whipple, right, the procedure that's done oftentimes is IR embolization of the complete, like the common hepatic artery, and you kind of get rid of the hepatic artery in that sense, and the liver, for the most part, will survive that just fine, just fine. And so we do have some evidence that you can get rid of the hepatic artery and the liver will remain functional and alive. It's not to say that we should treat it with impunity. But here's my provocative question to the experienced surgeons on the call. If we are to think this way, that we've got these collaterals, especially with regards to the arterial anatomy, why is it that we would consider, and I'm not proposing that we don't, but why is it that we consider like a perihilar tumor involving the left hepatic duct, but involving the right hepatic artery? Why do we not just sacrifice the hepatic artery? And why do we consider that unresectable? Just
I think
a provoking question.
I think that the problem there is the biology, not the anatomy. You have an arterial involvement of the contralateral lobe. So my concern is with the biology and the recurrence after the surgery, more than the technically could take off the artery.
Yes, and if I may add, the embolizing the artery, if you really want to push the, just a second, if you want to push the resection, Isabella, sono ancora in conferenza, ti richiamo. Ciao. Sorry. This has been well described. To embolize it first and then have the collaterals from the diaphragm and stuff develop and then resect the artery and resect everything. But the biology is the limit.
Just a question, Sylvia. Congratulations. Very interesting case. But my question, I'm convinced that you did probably the best treatment. But my question, do you discuss with the interventional radiologist and why finally the embolization was not chosen? Because we know that today interventional radiologists are more and more performant. And so why they did no, we don't perform any embolization and you should do surgery?
So they performed the arteriography. We are hoping that we could embolize the aneurysm and we have arterialization from the left artery, but we don't. So they go back, they call us and they told us that they are afraid of some rupture of the aneurysm during the embolization. And the surgeons, we are afraid also. So we decide to perform that with control in surgery because we are afraid of the rupture.
Okay, thank you.
And in the embolization, if we have a rupture at this point, it's an emergency, and we couldn't have time to reach the OR. So that's what we thought.
Okay. Thank you. Thank you.
Thank you.
Thank you, Sylvia. Two very interesting cases. I think there are no other cases to discuss today. They were not announced. I don't know if anyone has.
No.
So it was a very, very interesting discussions. Thank you all the presenter.
Okay.
Thank
Thank
you.
you so much.
Thank
you,
you.
Alessandra.
Thank
Bye-bye.
you, all of you. Thank you.
Bye.
Bye. Bye. Bye.
Bye.
Thank you. Thank you very much.
Bye bye. Bye bye.